get. Um, Thank you everyone who's joining our March open office hours on bridging the gap between EMS and hospitals, regulations and relationships. Today we have Andrea Abbas with the Michigan Center for Rural Health. Andrea is our EMS programs manager. And joining on Andrea, we also have Emily Bergquist. Emily is the director of the Division of EMS with MDHHS, and Emily will be starting off the presentation today. I will turn this over to you, Emily.
Good, exactly noontime, everybody. It's good to be here. I am glad to be able to chat with you all today. Man, I did some change. I shared, and then holy moly, my whole world changed, and I lost perspective. Okay. Hopefully we are seeing the correct screen, and I will continue on, and you stop me if you can't. This, you can see, is not a presentation I created for you, and I will not be able to go through at a great pace and get through all of the information that's in this just because of time. This particular presentation, when I gave it the first time, took about an hour and 10 minutes to get through it. But I thought that there was value, one, so that I'm kind of sending the consistent message to all groups of people about this particular concept of patient movement. And then this presentation is, freely shareable. So it has some links in it. It has a whole bunch of information in it, and then you all will actually have access to it. And then you can kind of peruse it on your own time. So if you don't know, we have a group that is a subcommittee of our Emergency Medical Services Coordination Committee that's called the Patient Movement Subcommittee. And they've been working for, I don't know, maybe around a year or so together, trying to work on like identifying the barriers to be able to move patients efficiently. And when we say move patients, you'll see kind of, we'll talk about it's more than hospital to hospital or scene to hospital. There's a lot of other work that ambulances do in the state of Michigan every day that I think not everybody is aware of. So that group meets regularly, actually monthly, and if you are interested in attending, we do operate it for the most part like an open meeting, and you would be more than welcome to attend. And if you would like to do that, you can just always reach out and we will gladly add you to the group. So these are the goals, and kind of understanding like the regulatory components from our side of the world. Obviously, hospitals have CMS requirements and LARA requirements, and then EMS has all of the MDHHS requirements. So the law that all of our stuff is under is Public Act 368 of 1978. If you didn't know, I'm not going to get into a whole lot of this, but all of the pieces and parts of our system are defined in the code. And there are a few things that are, really of note. I think, the definition of an emergency is important. What is an emergency patient versus a non-emergency patient? All of that is statutory. So we can kind of clarify that a little bit, but we can't really undo what's already in the law and already defined. Who can take a patient who's on a stretcher? That's all defined in here. And like what all those requirements are. So there are some things we can, I say massage or, work in gray areas, but there are some things when someone says, well, we should just do XYZ. I say, well, that XYZ thing does take an actual act of legislation. So it's not always as easy as we want it to be. So these are all the definitions. There's several slides of that. You can look at that at your own leisure. Then this next part here is about like what our particular role as the department is. And you can see like this one is very broad at the very beginning. We're responsible for the development, coordination, and administration of a statewide EMS system. Very broad. And that gives us all the rulemaking authority that we have. And I'll talk about our administrative rules here in just a minute. But in essence, this gives us all the authority to say like how ambulances interact with hospitals and how the communication works. Because in essence, what the code does is it gives us authority over the patients up until the point in time that the patient care is transferred to someone who's outside of EMS. So whoever that someone is outside of our law, whether that's a nurse in the emergency department or staff at a dialysis center or skilled nursing facility or behavioral health facility. It gives us the authority of the patient as long as it's within inside the EMS system itself. So these are, like I said, more things that we have to do. And then this is one of the things that's really important. So it says, everybody has to adhere to the protocols for providing services to a patient before the care is transferred to the patient or the hospital personnel. And so once a patient is like transferred to EMS, it doesn't fit inside like what a hospital considers their normal way of operating things. So when someone is taking a patient from a hospital to another hospital and they're kind of like in this middle land, this is where all of what we call the barriers, where the barriers kind of exist. And that's why there's been a lot of work in recent times to really shore up our interfacility transfer protocols that kind of give the medical control authorities some flex room to create a better system for this, as opposed to being in a hospital with a specific set of treatment plans. Now you're somehow in EMS protocols, and then you go back into a hospital's treatment plans. It becomes a little bit difficult. So that's kind of the concept of the MCAs and the protocols and how a patient is handled. And you'll see this is one that I wanted to hit on. MCAs, when we say a medical control authority, it is legally responsible to be administered by the participating hospitals. And any hospital licensed in the state of Michigan or surgical center that has an attached emergency department that operates 24/7, it has to be allowed to participate. They don't have to participate if they don't want to. And when sometimes hospital leadership will ask the question of like, why should I bother? Because these participating hospitals administer the system and they create, in essence, the rules for the system. There is an actual, gain for a hospital to be participating. And if, for example, you feel as a hospital inside an MCA that you're being, bullied by EMS and you're not getting the things that you need inside your system, please reach out to our office, because it really is supposed to be the responsibility of the hospitals. It's not supposed to be done without input from EMS, but it shouldn't feel like it's a constant war between hospitals and EMS, and we can work to make sure that that's handled appropriately. Okay, so I'm going to skip over that. That whole section is around like scope of practice and what a person can and can't do. This piece right here allows an MCA to kind of ask for a higher standard, or for a hospital to ask for a higher standard, but it outlines an ability for EMS to kind of appeal that. So I'm going to use something like completely out, like that wouldn't probably happen. But let's say an MCA says that you have to buy an interfacility transfer rig that's capable of taking ECMO, for example. Some really large, really expensive. You try to pass a protocol that says that is place, and EMS can come and say, like, department, this is not actually possible. The department can say, no, that's actually not okay to put that into a protocol and ask for that additional standard. We don't see this an awful lot because most of our MCAs work together to make sure that everybody is pleased, or at least accepting of what is in protocol. But just so you know, there is a way that if an MCA and the hospital's administering that MCA drive a protocol to be something that is unpalatable for the rest of the EMS system, that they can appeal it to our office. So this is the pieces when we talk about ambulance operations. When I was a paramedic who worked on an ambulance, I definitely had some preconceived notions around what our legal obligations were. Mind you, I did not actually look it ever up in the law, but now that I work in the state office, I definitely have a different understanding of how this works. So ambulance operations only have to staff one ambulance 24/7, 365. That's the only thing the law says about staffing. And it does not matter whether their geographic service area is one block or 1 county or 5 counties. We cannot enforce anything beyond one ambulance 24/7, 365. And then the second piece of it is that they have to respond or ensure a response to requests that are provided or requests from anyone for assistance, emergency assistance. So if, for example, you were to call and that one ambulance is 5 counties away, they could make sure that someone else comes in their stead. And so what this does is it creates a very difficult situation for us to be able to enforce on, whether an ambulance comes. So like we had to wait 3 hours for an ambulance. There's nothing in the law that says how long it should take to get an ambulance. And so we work really hard to make sure that that's not happening. But there is no ability for MDHHS to force an ambulance operation to do something faster. There's no ability for us to enforce them to increase their staffing beyond this particular thing. They have to be able to provide life support consistent with its license. So that means like if you're an ALS ambulance, an ALS agency, you have to staff an ALS ambulance. You can send a BLS ambulance, but you can staff it also, but you always have to at least have one staffed at your license level. And you always, always, always have to provide assistance to emergency patients without discussing ability to pay for that emergency assistance. Which obviously I'm sure you can imagine can create some financial strain for them just generally. This is a thing that's really important, especially for smaller hospitals. If, for example, you have the ability to send staff with an ambulance, you can use one staff person from the ambulance company and one staff person, licensed healthcare professional from the facility that's sending the patient, and that's considered acceptable staffing. There are some hospitals that do this all of the time, and it has alleviated a little bit of the pressure in getting an ambulance to take patients, but obviously hospitals are not staffed with 10 extra people on every single shift, so it doesn't work out all of the time, but it is a nice thing to have in your pocket if, for example, there's something going on where you need a higher level of care than what is available, or some sort of really specific skill set to be in the ambulance. You can send a specialized person along. So that's our law. Then these are rules, and these are just clarify the law a little bit more. So this is a new rule. I put this one in here because it's new. This is what was put into a rule after, there was a ruling on this in, I think, 2009, but an MCA does have authority for a patient when they are on the stretcher, even if they're a non-emergency patient. It's pretty clear. So they can now create protocols that kind of govern the treatment of a patient when they're on a stretcher in an ambulance, even if they're not having an emergency situation. And a lot of MCAs have chosen to do that. And then there are interfacility patient transfer protocols. There were new ones released in 2023. I'm not going to go into these because they are many, many pages long. There's one that's 815 and one 815S is the supplemental, which is the one that goes over like the things that are beyond the normal scope of a paramedic. So what we call specialty care or critical care, depending on who you're talking to. Paramedics, when they come out of school, are not trained generally to use ventilators, to administer vasoactive medications over long periods of time, to move these highly critical patients between facilities. Their training obviously is focused on that pre-hospital space. So there are abilities, hang on one second. My husband just got home, so the dog has to tell us about it. So those protocols are available for MCAs to kind of choose how they need to implement those inside their given geographic area. It also gives an MCA an ability to allow a different agency from a different MCA to come and take those patients. If, for example, you're in a place where you're super rural and you have a hard time getting critical care transport from your local agency, you could enact this protocol and then authorize people in adjacent MCAs to come in and take your patients. And some MCAs have been over the moon about this new option, and some MCAs have been a little bit reticent, because if you're in a competitive market, obviously your agencies don't necessarily want you to bring in someone else to do that work. But if you are in an area that is rural and you don't have access to these resources, obviously that's an extraordinarily beneficial to you. So those are out there. I believe everyone should be submitting everything to Chrissy by the end of the month this month. So hopefully, if you are a hospital person who participates with your MCA, this is not new news to you, but that link actually does take you to our website, and you'll be able to kind of look at that a little bit more there. Then there's a couple of other things in that space. There's 2 declaratory rulings. One's from the Attorney General's office. That's the one that actually lays out that protocols are still in play when the patient is on an interfacility transfer. So, because EMS is not necessarily employed by the hospital, that does happen in Michigan sometimes, but not most of the time by any means. There was a place that everyone was like, well, EMS doesn't have jurisdiction over those patients. Like, all of the care is designated by, this place or that place. And the AG came out in 2001 and said, of course, an MCA can do this. Of course, the protocols still apply. They should be able to utilize their scope of practice when they're taking these patients if it becomes necessary. And then the second one, the declaratory ruling, is from when Janet Olszewski was the director of, not MDHHS, it was before it was MDHHS, but whatever the department was at that time. And what it is in essence what enables that new protocol that we talked about, to allow MCAs to work together in order to make sure patients move appropriately by authorizing people to perform transfers that are outside of the geographic area. Before that ruling, it was kind of understood that every person who took a patient either had to have MCA privileges in the starting or ending medical control authority. And I'm going to use like random places in the state. So if you wanted to take a patient from Ontonagon County to Traverse City, you either had to be an ambulance provider in Ontonagon County or in Grand Traverse County. If the MCAs in those areas allow this to occur and, select this in the protocol, you could, call an ambulance service from Oakland County to go to Ontonagon and then take the patient to Traverse City. So I think that for rural and critical access hospitals, I think there's an obvious, you can see right away why there would be a benefit to allow you to reach a little bit further to bring patients longer distances, fundamentally just because, using Ontonagon as an example, there's one ambulance company there. It's a very small ambulance company, and having them go, 7 hours somewhere and come back is a very difficult thing for them to be able to work with. So that is that. That also links to that particular ruling as well. So the concept, and I know I'm like right up to my 20 minutes that I'm supposed to have, but I know there's going to be time for discussion. I think this is the piece that is really painful and kind of a constant rub point, is there are no rules or laws that say an agency must do non-emergency transport. So there's no law that says if you are a hospital and you need a patient to be taken because they need to have a neurological consult in 2 days at a larger facility, there is nothing that we can do to force someone to do that for you. And that obviously is a problematic situation, but that is how the law is written. So that's why we've worked so hard to try to open up the restrictions around ambulance movement for patients, to be able to allow resources to come from other areas to be able to move those patients. And then authority for the movement of these patients, like when they're actually going in the ambulance, it does actually rest with the medical control authority and then subsequently the department, because they have designated authority from us. But there are, tools for an MCA to utilize to be able to facilitate this, as we kind of talked about. It's certainly not perfect. And I think that we all know it's not perfect, but we are working really hard to try to at least I say write the unwritten rules so that we can all kind of work together to come up with the best solutions for the situations that we are in. And that is that for that. And I will stop screen sharing. So I can look at the questions in the chat box. Uh-oh, someone has a safety concern. Oh no. That sounds terrible. Okay, hopefully that there.
Oh, there she's back. Does anyone have any questions for, oh, go ahead, Becky.
So I have just a couple of questions. First off, thank you so much for the presentation, Emily. Um, when you talk about interfacility transfers, if I had an EMS staff member say, I mean, our ER provider writes orders for the patient for transfer between locations until they get to the next facility. If EMS states that they don't need those orders, they're going to be following their own protocols. That's where you're saying that that's that kind of gray area, correct? So they can go off of their own protocols, but the orders that are written are also available to them.
Yeah, so it would be kind of how your interfacility transfer protocol is written. Like this is it's an interesting thing because some paramedics have a very strong understanding of, how to handle those orders and but not all. And that gets into that, what is their level of training? Most of them, I think, would choose to take them just because you don't want to switch a patient's treatment plan, but that is not always going to be the case. So yes, that is the gray area of, I know the physician really wants that level of care or that specific thing to continue. But if the paramedic is, like, we'll say, not comfortable with the medication or they're not sure of how it works or whatever, it is always possible that they'll say, like, I don't feel comfortable with those orders, or those orders don't mesh with what my treatment protocols are, and we're going to use our treatment protocols. So yeah.
Okay. Similarly, when you were talking about the newer laws that have come out, EMS having authority on patients when they're on the stretcher, if the patient's in the hospital, and that I feel like on the hospital side, a lot of times we wonder where that cutoff is, that we're transferring care to EMS. And usually we do that when report is given and that's our official handoff. But what I hear you say is almost it's once the patient's onto that stretcher that EMS now has authority, and that's when the change occurs.
Yeah, I mean, so like I can use an example like Wayne County, which is obviously big and highly resourced MCA. They have a great patient transfer protocol, like transfer of care protocol. I should use all the words. They have a great one where it actually like defines exactly how each one of those is supposed to take place, and how, like what is supposed to be given and what is supposed to be taken, and like where that line is. So they've done a really good job of that. And it's been an interesting conversation because I've had people say, well, the MCA doesn't have authority over the people in the hospital. True. That's very true. However, it helps everybody. Like if Wayne County can do it, just to be clear, like anybody can do it, because Wayne County is managing a ton more people than a lot of the other MCAs are. And everybody really likes having that, like, this is the checklist and these are the steps that you go through for sending and receiving these patients, and how these conversations take place and what everybody needs to have. And I know that it took their work group a long time to get that into place, but I highly encourage any MCAs and hospitals that want to do that to get that together so that everybody knows, like, this is when now it's your patient versus when it's, our patient. And hopefully you never run into some wonky situation, but I'm thinking of like, you give report as the nurse and you walk away and then the patient arrests, and now like what, that would be really terrible if they were still in the hospital bed. And then like there's a lot of pieces like of really weird things that could happen. So yeah.
Thank you.
You're welcome.
Any other questions for Emily before we move on to Andrea's portion of the webinar? All right, Andrea, you're up.
Okay, can everybody see my screen?
Yes.
All right. So my presentation is a little bit more theory-based than regulatory. So this will be a nice transition into a different kind of conversation. When I was thinking about putting this presentation together, I thought, well, let's start with who EMS providers generally are. So this is peer-reviewed research. And the personality traits of EMS providers are a little bit unique because the work we do is quite unique. We go into uncontrolled scenes. We sometimes deal with things that are impossible, and we find solutions to those dynamics that can play out on scene. So research personality traits. So need to be in control. We can be obsessive, and that can be a good thing when you're out in unsafe environment with a patient that is potentially having a medical emergency. Being able to hone in on something and really be persistent with it is important. We have a compulsive nature to us. We react quickly. We're trained to react quickly. We're highly motivated by internal factors. So we have generally very strong value systems, and that's what draws us to this work. We're action oriented. We have a high need for stimulation. So we can be easily bored. And again, the nature of the work fits with someone that has those personality traits. We are risk takers, and we do have a rescue personality. And we tend to be very dedicated to our work, and we have a servant mindset. So we have a demand to be needed. So of course, this is peer-reviewed research. It doesn't mean everybody is cut the same way, but those are the personality traits that stood out when they did the research. So when we're talking about building relationships and we're talking about strengthening collaboration, we kind of want to know a little bit about who we potentially could be dealing with, and that paints a bit of a picture. In our field, traditionally, people move up through the ranks. It's not always the case, but often you'll start on the road in an ambulance service, and then you will move up through the ranks. So those personality traits sometimes don't translate well into leadership roles, and you have to unlearn some of those behaviors. So you might see that in some of our leaders as well, that we have a little bit of an edge to us. We tend to be very direct and straightforward. We move quickly, we take action. Some of those traits can definitely be translated if you're dealing with, a director or a supervisor. You may see those traits in their personality, and it comes from years of dealing with emergencies on scene. So what's the work environment like? Well, many of you already know some of these things, but for those of you that may not, I'm going to go over some of the things that maybe people don't think about. So we have an extremely autonomous work environment. We are a mobile ED. It is just us and the patient. We follow the protocols, as Emily had alluded to in her presentation, but autonomy is there, and oftentimes our autonomy needs to be stretched when we get into homes or we get into situations where we need to get the patient out, or we need to do something that is going to save someone's life in a very short period of time. So with that comes performance pressure. So, if you're seeing crews come in and out of the ED and they seem to be moody, or they seem to be tired or fatigued, bearing in mind that each call has a demand, and we are facing a workforce shortage. So that demand is increased, and you might see some of that showing through when you're dealing with EMS professionals in the field. Safety is an issue for us as well. I've heard some conversations within hospitals about, some of the things that can transpire. I also started my career in a hospital working in an ED, so I understand some of the dynamics that can play out in an ED. But in an ambulance, it's just you, your partner, and the patient. And oftentimes you're in a home and you're dealing with a dynamic that could play out very quickly, and you don't have any weapons. And oftentimes we have to be very alert and understand what's going on. So when you see a crew bring a patient in and, things look a mess, always remain curious as to how that mess occurred. There could have been some things going on in the back of the truck that were safety concerns, and things can become complicated pretty quickly. There's also some increased psychological, there's some backstory going on and some psychology going on in our industry right now. We've had some historical legal cases take place where we are now seeing providers criminally convicted. I just saw a follow-up today for the Elijah McClain case, where the Aurora Fire Department, who was involved in this case, 2 of their providers went to jail for criminal charges. I've watched the footage. I've seen what occurred. I won't share my opinions, but I would encourage you to watch the footage if you're wondering about these cases and what went on. But we have 2 paramedics that are now criminally convicted for actions that they took in the best interest of the patient. The Earl Moore Jr. case is also quite complicated. There was some breach of protocol there, and I've lost track of actually where they're at. I know they were on trial, but both of these cases have kind of rocked the industry and gotten providers thinking about, oh, so if something happens with us with a patient, we are liable and potentially could go to jail. So this is something that, in my opinion, has scared quite a few folks, myself personally. I'm finding myself taking charge much more on scenes. I'm finding myself being much more careful, and I would be more than willing to walk away from a position where I'm being forced to put the patient or myself at risk, because these are real cases. So something to kind of keep in the back of your mind as you interact with EMS professionals. And then the working hours, 24-hour trucks. Anybody that follows some of the content that I create, I'm not a fan. Have I worked them? Would I go back and work them again? Potentially. But do I feel like they breed a healthy culture or a healthy physical or mental state? No. But much of the industry is working on working short staff. They have less staff, and a 24-hour staffing model does allow for filling that schedule. But it's really hard to get downtime for crews to actually sleep. And the best clinical care happens when you're well rested. So some of your crews in rural areas, you might see on a 48-hour shift or even a 72-hour shift. Please keep that in mind. They could be quite fatigued when you're dealing with them in report or with patient care. System demands continue to increase. If you look at anything that's published from the Bureau of Labor and Statistics, I can never say statistics. The demand is going to continue to increase as boomers continue to age. And so we know call volume is going to continue to increase in most communities. And with that, there's going to be more demands for 911s. Interfacility transfers are extremely important. It's part of the continuum of care. And as we're seeing, some dynamics can play out where there's a demand to move a patient, and there's also a demand for 911 service in a community. And then something that people don't think about as well is in rural communities and urban communities, ambulances are moved around differently. So they might be turning a call, dropping the patient off and going back to a station and then coming back out again. Or what system status is they turn calls and they go sit at specific locations in the county. So this also can be a contributing factor to fatigue. If it's a busy day, they may never see their station. They may be sitting around the county waiting for the next call. And that also kind of has its own dynamic when you're sitting in an ambulance for long periods of time, going from call to call to call. You're eating your food on the way. You have to find a good bathroom that you can use on the way. And you're in that space for the day. And then the diversity of expectations that's developing for us. So the scope of practice since I've begun as a provider till present day has increased substantially. And I think that's a great thing, but we also have to understand when things start to increase and expectations start to increase, that's additional charting, it's additional training and education, and it's just simply additional work. So the advent of, instructor coordinators, the advent of community paramedics, the advent of additional things on scene like, naloxone leave behind kits, which are really great, or entering patients into data systems after the call in addition to paperwork, additional charting requirements, additional follow-up calls. If you're already in a busy system and you need to get rest and you need to eat your lunch and you need to do all your charting, you might find that the diversity of expectations can become great pretty quickly. And there's always a good intention behind these expectations, but sometimes what you'll find is that it can overwhelm the EMS professionals that are trying to accomplish all of these expectations. And I can't help myself. I definitely have to comment on the level of pay. The level of pay is not great in most systems. EMTs can start out at as little as $12 an hour. Paramedics in some systems are making less than $20 an hour. So, you know, there's some social drivers of health and financial implications to that. So when you're looking at an EMS professional that is earning $12 to $13 an hour, that can make housing insecurity an issue and also food insecurity an issue. They may be working 80 hours a week to keep the lights on and to keep things moving. So that complicates things a bit. So how do we strengthen relationships with EMS? Well, when we foster those relationships, we need to think about who we're fostering those relationships with. So if you're a hospital system and your EMS barn is just a stone throw away, it's great to just pop over and have a chat with the director from time to time and start to cultivate those relationships. The EMS supervisor in a lot of the corporate systems is really the person that you want to get in contact with and start to forge those relationships. That is going to be the person that's out there every day with road personnel, and they're going to really understand the lay of the land. So making good relationships with the supervisors is gold. The supervisors will tell you what's going on. They may even come in each day. You could set up an expectation where you come in each day. I did this in a system, in one of my rural systems. We would just come in the morning and say, we have this many trucks on. That way the hospital understood, oh, you only have one truck on today? This isn't going to be a good day. Let's work together to figure this out versus, oh, we have 3 trucks on. Great. We're not going to have any issues getting patients out, hopefully. So giving them reports and opening that line of communication is really, really great. And that starts with forging those right relationships within the community. Then completing ambulance ride-alongs. If you've never been in an ambulance and you've only seen it drive by, it might be a good idea if you can form a relationship where you can have an agreement, you can complete ride-alongs, and vice versa. They can come into the ED and spend some time there and understand what goes on in the background in an ED. Explaining to them some of your expectations will help them understand why, for example, you need to get this patient out at a certain time, or you have a timeline that you need to follow in moving patients. A lot of the EMS professionals don't know those things because they've never been communicated. So ride-alongs on both ends of the spectrum, I think it can be fruitful. Educating and training together. So creating forum groups where you can have discussions openly, like maybe you create a private electronic group where everybody's in that chat and they can kind of chit chat together, doing trainings together. So, great relationships can be forged if you do an AHA course in the hospital and you invite the EMS providers to that, then you naturally form those relationships. And having regular meetings. If there is if the geography favors that could be really great where, the crews are paid to come to the meeting. The hospital administration is also, paid to come to the meeting. You meet up and you exchange some information. Maybe you do run reviews together where you follow a patient from the time they hit your ED to the ambulance or from the ambulance to the ED, and you talk about what could have happened or what could have went better. Run reviews is a great way to forge that relationship and increase clinical quality. And then, Emily gave you some really good insights on what the medical control authorities are and how they work. Understanding those protocols can be really beneficial, and knowing where you can go to access them. Like there's a great app you can download on your phone and it's free. You just click the button, or no, it's $1. I think it is $1. But it's $1, you click the button, you can access all the protocols. So if a crew comes in and they're saying, you know what, this is against our protocol, you can just go in there and take a peek and look at what the protocol actually is and have that conversation. So understanding medical control authority protocols. I guarantee you though, these crews are not going to misguide you. They need to know their protocols inside and out, and they're going to be telling you exactly what that protocol is. And then understanding the expectations for patient care. So this is where I've seen a lot of conflict. During patient care handoffs, that can create some conflict for a couple reasons. One is crews want to give you a report when they bring a patient in. And if the nurse is not listening to them and they're off doing something else, that can be seen as confrontational or disrespectful. And the crew will definitely take that to heart because they were providing patient care. And that goes both ways. So when they come pick up a patient, they should be listening to you, and that open line of communication should be there. If it's not, someone needs to say something. And I think the biggest mistake that folks make is they notice it, they get upset about it, and they say nothing. They just let it happen. And then that resentment and tension builds, and then the relationship continues to deteriorate. So having that open communication of saying, hey, I'm giving you a report. I need you to listen for just a few minutes, to set the boundary and let folks know, like, hey, this is really important to me. Paperwork. So oftentimes, like psych transfers, specific types of transfers require specific types of paperwork. There are specific boxes and things that need to be signed off on for billing. So if a crew approaches you and says, hey, I need this information, they need that information. So we are required to go over a lot of that paperwork before we take the patient for legal and liability issues. And so if we come back to you and ask for something on paperwork, I guarantee you the crew is not giving you a hard time. They don't enjoy it any more than you do, but they do need to secure those signatures or paperwork. And then company policies and procedures. So again, what's the expectation? Tension can sometimes lie in the provider's decision to do something versus what's policy and procedure for you, or perception of what's best for the patient. So there have been many times in my career where, I didn't feel comfortable with something, but the hospital also didn't feel comfortable with something. And it's who's going to actually make that decision. So, if it's, someone giving birth and you're in a rural landscape and the provider needs to come there, they may urge you to let them stop at the ED, but the ED may say, no, just keep driving. And that can create some tension on that provider where, am I going to birth this baby by myself in the back of an ambulance? So company policies and procedures for an ambulance service versus an ED and what's preferred can create some tension if there's not an open line of communication. Same with patient care decisions, which kind of is what I just mentioned, right? Who's making the decision? So keeping in mind when that provider is with that patient, they are ultimately responsible for that patient and the decisions made. So communication is super key here. And then understanding the scope of practice. So what a lot of folks don't realize is there is a level to the scope of practice. And oftentimes in the ED, folks don't know who's an EMT, who's a medic, who can do what. So at the base is an EMT, so they can do very basic things, take vital signs, do some bandaging. They can administer a few meds, not too many. And then as you move through and get to advanced, there's a few more scopes of practice added. And then the paramedic typically has this full scope of practice. But there is another level, and that's called the medical intensive care unit paramedic, or in some systems, they're trained a little differently. They're called specialty care trained paramedics. Those are the folks that are managing vents, they're managing multiple drips. They have an expanded scope of practice when it comes to what they can and cannot transport. So going back to operations, when you're waiting on an ambulance to transport a patient, if it's a vent patient, there are going to be far fewer providers that have that level of license and training to be able to handle that patient. So if you have to wait a little bit longer, that potentially could be why. As you increase in scope, what we're at least seeing in most systems is there's a shortage of paramedics, and there are fewer MICU or SCT trained paramedics. So getting that right ambulance to the right patient is also part of this continuum of care and system of care that you see play out every day. And then community paramedics are also coming about in communities. They are doing some in-home care and filling the gaps there. So high utilizers can be addressed, chronic care conditions can be addressed. So there's a lot of different scopes of practice out there when it comes to EMS professionals. So I've already mentioned some of the sources of tension, but oftentimes what I've found is the unwillingness to have the difficult conversation. I was just privy to conflict the other day. I was riding in an ambulance service, and the hospital, instead of talking with the crew, called the EMS director and said, hey, your crew did this. Then the supervisor went to investigate, and this automatically created tension, right? Because the crew, their first question was, why didn't the nurse say anything to me? Why did she choose to not say anything and then call my boss? That's not a relationship building. So we have to be very careful there. You want to have those relationships with EMS professionals. They are highly trained. A paramedic spends 2 years in school. There's an additional 6 to 8 months of training for MICU paramedics. So we need to be communicating with them and letting them know and setting boundaries with them, and vice versa. There needs to be an open line of communication. So to prevent miscommunications, there needs to be communication. Never assume anything, always ask questions. You'd be surprised what folks assume about what we're doing or how we're doing it. And oftentimes those assumptions are linked back to a lack of knowledge somewhere. Like, there's a lack of knowledge on a policy and procedure, or there's a lack of knowledge on a protocol, and there's an assumption built around that. The other thing that creates tension is turnover, and this is no fault of anyone's, but the shorter a system is with providers, the more tension is created, right? Because you are waiting on us. And sometimes we are waiting on you. So another example of this is I worked in a system for quite some time where the ED was short for a duration of time. They didn't have enough staff, and their volume was just out of control. And what would happen is we would come to drop off a patient, and our metrics are, we drop the patient off, turn care over, and come back to the truck. And that is measured. So that's a performance measure for us internally. What was happening is crews were arriving and they would have to wait 30 minutes for a bed. We call that a wall time. And that will stress the system for us. So understanding that, we can't just wait most days. We may get a 911 call while we're standing there. Now there's tension. Hey, we have to go. We just got dispatched. We have to drop the patient off. And then it's seen as disrespect. And then the tension grows. And then we're seen as being pushy, but our company has a 911 pending. So it's that open communication and understanding. There's a demand. We're short-staffed. We have to put the patient somewhere. Where can we go? We understand you're overwhelmed too. That bi-directional overwhelm can lead to a lot of unnecessary conflicts. And then just misunderstandings over stable versus unstable patients. We talked a little bit about this earlier, but really understanding if this provider is telling you they're uncomfortable, there is a reason behind it. And I'm hoping that provider will really clearly convey to you what the violation is, or maybe there's a dosing issue they don't like, or maybe they need something from you that they're not communicating. But ultimately, going back to the criminal cases and the things that are going on right now with liability, your providers are being very cognizant and careful, and they want to do the best thing for the patient. Every organization is driven by the patient. So when they express a concern, it's about the patient. Care decisions we touched on, shift change. So I want to mention this quickly. Many of the systems I was in, especially in rural areas, you need to know when shift change is for the ambulance services. So is it staggered? Because in rural landscapes, typically it's not. The crews leave and come on at the same time. So knowing when that shift change is and then making an effort to not hold those crews over, you would be amazed. All right. So if they're working 24-hour shifts and their shift change is at 8, you do not want to call them for a transfer at 7:30. Okay, shift change is coming. I'm going to call at 8:01 when that fresh crew is on, because it creates tension when we're holding crews over. And some of that responsibility falls on the EMS agency as well. But if you call for a transfer at 7:30 a.m. and the supervisor says, we will be there at 8:15, they need to convey to you that's shift change, and there needs to be an understanding there. You don't want a crew that's been up for 24 hours driving a patient an hour to a hospital. You want to wait so the best patient care is provided. It's not that they're trying to delay the exit of the patient. It's a safety thing and it's a respect thing for the crews. So this is something that often times I find is not communicated well, but if you have a close relationship with your ED and your EMS agency, in those meetings, those things should be talked about, and there should be an agreement made where everybody's educated. ABC ambulance shift change is at 8. All transfers need to be out by 7, and we will not call you between the hours of this and this for a transfer, obviously, unless it's an unstable patient, right? And then calls after 11 p.m. I did work in a system where they were really, really focused on wellness. And one of the things they did is they made an agreement with their ED that no non-emergent interfacility transports will go out between the hours of 11 p.m. and 6 a.m. And that is so crews that are on 24-hour shifts can get some rest for safety. And I thought it was a great idea. They implemented it. They worked closely with their ED. It was working well. Everybody knew the expectation. And that was one of the systems I worked in where I felt they had the best relationships. They were very, very close knit, and the system worked really well because they were working so well with their hospital. So with that, I will open it up to questions.
Thank you, Andrea. That was amazing. Does anyone on the call currently have any questions? Comments?
Oh, thanks, Heather. Yeah. All right. Thanks, Becky. Yeah.
I guess I'll ask just a general question. If any of the attendees here on the line have implemented anything within inside their critical access hospital or their emergency department that has fostered relationships with their EMS. If anyone's got any best practices that they could share or things that they've currently been doing.
We have been doing ride-alongs for our new RNs and EMS, and that seems to have been a great improvement. We still struggle with the tensions of bedside reporting. Even implementing that in a timeout has not always gotten buy-in, so we continue to struggle with that at times. And then it seems hit or miss for the understanding of times for transfers. It feels like it gets better and then it goes right back to it. So the other day we had a transfer at 5 o'clock in the morning when the shift or the staff was getting out EMS changes at 6, and it was over an hour away transfer, but they had had multiples prior to that and yet had gone like 20 hours previous without any transfers. And so it feels like, yes, in that situation, I just wanted staff to be able to communicate and say, we'll wait. Can I take it at 6 o'clock when a fresh crew comes on? Yes, that would be fine. Or something. Not knowing what's coming on the next shift is always a questionable piece too, right? Because I might end up with another transfer that's needed or an emergent case, and then you get that pushed back. But I just stress communication over and over and over.
Yeah, it really does come back to, some of the uncontrollables, right? Like the uncontrollable is, what's the culture like within the agency and how are people being held to that accountable standard? Like what's the cutoff? And then the other aspect, right, is the communication. So them calling you and saying, hey, this is our policy. Like if you have that policy outlined, like nothing goes out after 5 a.m., then so be it, right? But if it's 5:30 or 5:45, then that's the policy. So that crew that's on needs to come get that patient. The other thing that's really good too, overnight especially, is to have a call, right? Where the EMS director and the hospital works together, where after a certain amount of hours on, if you don't get downtime, you just call it. You just say, you know what, after 3 calls or X amount of hours being awake at night, it's a call. Like all transfers halt and everybody goes to bed. So I always recommend that too. But yeah, I mean, the ability to cross, like to share scheduling between the hospital ED and the EMS agency could be really fruitful too, where like the nurse manager that comes on that day and some of the leadership team members can say, oh, this is, I can access and see how many ambulances, I can see who's working. And so you have an idea of like, the shift changes in front of you, how many ambulances are staffed are in front of you. That could also be a way to really cultivate that cohesion between the two.
I was able to also attend an MCA meeting earlier this year, and I normally don't. And from comments there, and then comments additionally from EMS, I'm going to begin sharing some of our quality data with them for our STEMI and stroke and trauma certifications because I'm hoping that those numbers and those initiatives will be enough to help with understanding on this is a potential stroke patient, but it happened 18 hours ago. I don't know why we have to transfer them when they're still in that 24-hour window or some of those other pieces. So
Oh, I love that. That's a great idea.
I see we have another hand raised. I apologize. LL.
Oh,
Crap.
Yep,
Sorry.
sorry. This is Lacey from St. Francis Hospital
Yep.
in Escanaba. So I don't know if this is necessarily considered a best practice, but one of the things that we started doing was we developed a joint operating committee with our EMS personnel as well as our helicopter or flight crew because there were relationship issues between the ED and EMS and the flight service. So rather than having grievances that are just continuing to fester and harm those relationships further, we're getting together once a month in the room to just kind of help each other understand, where we're coming from with issues with, either transportation or whatever it may be, staffing, but also to kind of resolve those and move forward.
That's great. Yeah, that sounds awesome.
This is Heather at Eaton Rapids. We've also had some communication issues, some relationship issues with our local EMS, and just some little things we've done that have come out of some RCAs. It really boils down to, like you said, Andrea, communication. And I think that comes from the top and, role modeling that for sure. So just, it sounds so simple and probably very trivial, but it was very important when our new ED manager came on board. She just had, a basket full of snacks and candy and treats in her office, and to let the EMS, staff know that they were welcome and appreciated. Unfortunately, some of their leadership was recommending that they don't take it and not to be friendly with our ED staff. So there was, needs to be some continued discussions, but
Yeah.
Just those little things to let them know that we really do appreciate the hard work that you are doing for our community, and we can't do this without you. And just those little things, it's just a small gesture. And who doesn't like treats and snacks, but we don't have big budgets here, we can't roll out the red carpet, but we can surely give you a snack and a drink and, let you know that we care about you.
So I love that. And I'm glad you brought that up because it is the little things. So when I think back to like the systems I was in where I felt like a sense of warmth and closeness, my fondest memories, I worked in a system where the ED had this really nice coffee pot with all this like creamer and, options to put in my coffee in little cups. And at 3 a.m. when I got woke up to take a critical patient or even just a inner facility, I would go in there and grab my coffee. And I just remember that warmth that I felt, right? Where they knew they woke us up and we needed coffee, and we would grab the coffee and then come back and get the patient. But those little things really do go a long way. If you can provide some coffee, some snacks in busy systems, most of your providers haven't eaten. So for them to be able to grab a snack is really helpful, but it is the little things, the ease of getting into your linens, for example, and getting the things they need, making those things extremely accessible to them. It creates this sense of welcomeness and warmth that is like on a different kind of psychological level. Yeah.
Yeah, thank you.
Yeah.
Well, we are on the top of the hour. I wanted to thank everyone for joining today. Thank you, Emily, and thank you, Andrea, for sharing your expertise and knowledge. And the recording and PowerPoint presentations will be available within the next week. Thanks for joining, everybody.
Of course.
Thank you.
Thank you. Thanks for inviting us, Amanda.
You're welcome.
Bye,
Thank you,
everyone.
Emily.
Goodbye.